Hi, it's Dr. Centeno, and thanks for joining us this afternoon. This is You've Got the Power, and today we've got an interesting topic. We have a randomized controlled trial that we're performing at the Centeno-Schultz Clinic in Colorado on chronic low back pain that would normally require a lumbar fusion surgery. But the patient instead will be treated with our platelet-based DDD procedure. So I'm going to go over a short presentation on all of that, what that's all about. And then obviously then we'll go to questions. As usual, you can ask questions about this or really anything else or any other topic. So let me go ahead and share my screen here. Again, today we're talking about the lumbar DDD randomized controlled trial that we have ongoing at Centeno-Schultz Clinic. And then we'll go to questions after that. So let me start from the beginning here. Pick up a pen. Okay, so as I said today, we're going to be talking about candidacy for our low back DDD study. And these are patients who would normally be thinking of getting a low back fusion. And instead, this would be a no-charge series of treatments using platelet-based products to try to avoid this surgery and then looking at the outcome of that. So we'll get into that. So Centeno-Schultz, in case you didn't know, in Colorado is the HQ or headquarters site for the Regenexx network. The Regenexx national and international network has about 85 clinical sites right now. And that's growing pretty quickly. We'll probably be at 100 US sites by the end of this year. That Regenexx network is very hard to get into. We keep the quality of providers and the training requirements extremely high, so that anybody that is going to a Regenexx provider knows they're getting orthobiologic care at a substantial cut above the average person out there. So we do that vetting for you. And as a result of being that HQ site, we perform a lot of lab-based studies. These are pictures of our labs here. We have a lab that focuses on research, on orthobiologic research that's done in more of an in vitro setting. And we also have a processing lab, state-of-the-art processing lab, that's CGMP class air handling, where we process things to treat patients, but also to do the clinical trials that we get involved in. And right now, one of those clinical trials is for low back pain patients. So what is DDD, or degenerative disc disease? That's when the spine begins to lose disc height. You can get some bone spurs. The facet joints get arthritis. There's often disc bulges, which can irritate spinal nerves. There's some degenerative instability. And the most common solution for patients who just fail conservative care is to get a lumbar fusion. And that's when the surgeon goes in and bolts the areas together. The big downside to that is adjacent segment disease. So that means the areas above and below the fusion start to get worn out. So we solve one problem and create another. So fusion really isn't definitive treatment for this as much as it is bolting parts of the spine together and hoping that that reduces the pain. So can we prevent the need for a low back fusion? We use a functional spinal unit approach at Regenexx. We have now for quite some time. And that means that we use platelet lysate, which is the growth factors taken out of PRP, and a prolotherapy mix injected with precision guidance into the ligaments to try to treat the degenerative instability portion of DDD. We also use high-dose PRP injected with precision into the facet joints that have arthritis. And then same thing, platelet lysate, but an anti-inflammatory mix injected epidural around nerves, and then platelet portoplasma into the muscles. Now, we can also add disc injections on top of that, but this study is extra discal. And we've used the DDD procedure now for quite some time with really good success over the last decade. In general, the registry data shows it works about 80% of the time to avoid the need for a lumbar fusion. Um, but we also need to do additional research beyond just retrospective registry data. So that's why we've undertaken this randomized controlled trial. And this is a more rigorous research format. So the general inclusion criteria, and this is sort of simplified for this, would be a lumbar fusion candidate, meaning someone with chronic low back pain, they failed physical therapy, they still have disabling pain. The patient can't have any prior surgeries or prior fusion. Low back pain needs to be the main problem, and for the duration of the study, you can't receive any other types of care but this, or things like, let's say, a physical therapy program that may be added as part of the research protocol. And patients are randomized into the real treatment or a faked procedure. So anesthesia is used to keep the patient blinded, meaning the patient is put to sleep. They don't know if they're getting the real procedure or not. If for some reason they didn't get the real procedure and they had no results, then they can switch over after 2 treatments into the treatment group from the sham group. The DDD procedure is free of charge to the patient. Now that's a substantial value. These procedures tend to run a couple $1,000s a piece. So that's going to be $6,000 to $7,000 worth of free care if you qualify for this study. So if you're interested to see if you're a candidate, contact Aaron, our study coordinator. That's Aaron Dodson, PhD at edodson@Regenexx with 2 X's.com. So let's go to questions now. I'll stop my sharing and see if we have any questions to answer about this or really anything else. So let's see where we are on the question front. Rich, I'm very familiar with Centeno-Schultz Clinic because I've been it's been driver for my wife and daughter who have been traveling from Oklahoma to get injections. I'm 67 years old, retired and fairly active golfer. For the last 6 weeks, I've been suffering with nerve-induced pain and muscle spasms originating in the left side of my neck and radiating out through the shoulder and shoulder blade and into the upper arm, sometimes into the forearm. I'm currently going to PT and had a 3 Tesla MRI. Yeah, Rich, so if that's due to cervical degenerative disc disease and or disc bulges, that's generally something we treat. Happy to have one of our docs take a look at that next time you're there with your wife or daughter, for sure. Regenexx, Sim Advanced by Dwayne Moore. Does it help herniated discs? I have one today. So much pain, Alice. Yes, so we use a similar type of treatment to treat herniated discs in the low back or in the neck. Now, that's not what this study is about, but certainly that's how we would do that. Regenexx, Sim Advanced by DB. Does DDD procedure work for slipped discs? Same thing as above. We use this kind of procedure to treat things like that with a little bit of modification over the one I just described. But yes, in general. Darian, what's your opinion of A2M injections? I think they may help. We've used them and we've used them on a less frequent basis than PRP, platelet-rich plasma, just because there's a lot more research on platelet-rich plasma than there is on A2M in clinical treatment. So where I've tended to use them in my patients are when the focus is on trying to reduce someone's arthritis load over time. What A2M is, or alpha-2 macroglobulin, is a molecule that tends to quench the pro-breakdown, pro-inflammatory molecules in something like a knee that swells a lot. So if I've got a patient where we're already doing some proactive PRP, let's say they've got mild arthritis, and we are trying to see if we can reduce that arthritis and slow it down, I'll use high dose PRP with some A2M added. So I think it's a good treatment. Now, is it some sort of miracle cure all by itself? No, it's not. But it's a good adjunct, I think, to PRP. It's been advanced by Harry Winston. Is this study only being done in Colorado for algo cells? Yeah, only Colorado's got the infrastructure necessary to do these kinds of randomized controlled trials. As you might imagine, doing a randomized controlled trial takes an immense amount of work on the part of a study coordinator. It's like herding cats. They've got to make sure that everyone gets specific things. They got to make sure that the patient gets put into the right group, that the patient stays blinded. Literally, the job of the study coordinator is to babysit everyone to make sure all of that is happening. And only Colorado has a full-time PhD study coordinator to make sure that all of those things are happening. Darian, is there any significant evidence that PRP can slow down or halt the degeneration of cartilage? If so, would getting yearly injections be ideal in order to prevent severe arthritis down the road? Good question, Darian. I did a blog on this not too long ago. Let me see if I can pull that up for you and see what we got going there. Let's microphone down here. Let's see here. Okay, so this was as of 2021. Let me go here and share my screen. So this is a blog as of 2021. You can go to the Regenexx website and then go into the search feature, which would be here. And then you can, I would just type in PRP disease modifying, and it should come up. And it just goes through whether or not we have evidence that PRP is disease modifying, which is what you're talking about, meaning do we have research showing that PRP can reduce the likelihood of arthritis getting worse? And the answer is maybe as of 2021. Now, I haven't done this particular study deep dive since then, but as of 2021, the answer was a maybe. And I'd go and talk about different things here, but definitely look that up because it sort of goes over that very concept. Sure, happy to help. Regenexx, been advanced by Sherry Kopp. How long does it take to recover from each DDD treatment? Does the study include one treatment or more than one? I believe it's 2 treatments, not just one. And I believe those are 4 to 6 weeks apart. Recovery from DDD for most patients is pretty quick. I would say within days, most patients are recovered. So pretty quick recovery from that kind of treatment. Barbara, I saw one of your blogs that some types of medicine for osteopenia or osteoporosis is not good. Are there any medicines that are good? And would any of this affect bone marrow construct treatment of OAs in the knees? Yeah, Barbara, my overall sense is that our treating of osteoporosis with drugs that kill off osteoclasts are the cells that break bone down, is one big human experiment, meaning we don't really have any long-term data on these drugs in the 10, 20, 30-year horizon, what happens, because it's a relatively new concept over the last 10 or 15 years. So my sense would be that you'd be a lot safer doing bioidentical hormone replacement, meaning treating the hormones that are messing with the bone density. Now, it may be too late to do that. I don't know how old you are and where that fits. You generally want to start bioidentical hormone replacement within 5 years of menopause. But that's my take on it. Finn, do you record the fluoroscopy imaging of each procedure? Just wondering if you could get Regenexx practitioners to watch all these as training rather than an expert from your procedures, but limited to you. Yeah, Finn, that's not going to work. When it comes to training these kinds of procedures, there's more than just the injection pictures. There would be, in fact, I was just thinking about this week. So when it comes to, for instance, trying to determine, I think as we've talked about before, whether a 0-1 injection is in the vertebral artery, there's no substitute for doing that several hundred times and getting a sense of which flow patterns are usual, which flow patterns are not, which ones are unusual. We had a patient this week, for instance, who had severe kyphosis. That means a very forward head position. We've got one of the most experienced rad techs in the room that I was in the country. She's got more experience doing high-level interventional spine than 99.99% of the rad techs out there. And because of the severe kyphosis and the patient's decreased bone density, the patient was not set up correctly for the procedure, which thankfully I was able to recognize pretty quickly and compensate for that. But there's just no substitute for years and years and years of doing this stuff. I would say that any of the doctors I've trained within their first 10 years of doing this wouldn't really understand what the problem was and why this patient was set up incorrectly and how that increased risk dramatically for the patient. Luckily, I was able to quickly identify it, make some changes, and everything was great. But that's with one of the most experienced rad techs in the country. And it just was the way this particular patient was built was unusual. And that's the hard part about medicine, is recognizing those small differences that can make dramatically bad things happen. So I wish it were that easy, but it's not. And had that patient been set up by someone without her experience, it would have been even a bigger nightmare, because it was very easy for me to relay to her what the issues were. And she said, oh yeah, I'm sorry, we'll correct that. Mark, single level laminectomy excludes me. It would for that study, yes. Pia, can a bulging disc around C5-6 somewhat heal on its own if the neck curve is restored? Certainly, Pia, restoring the neck curve will reduce the biomechanical forces on the disc itself. Now, is that enough to get the disc to heal? Probably not, but it could. Realize when you lose the lordosis in your neck, what happens is all the weight of the head gets pushed forward onto the disc. So when you restore that lordosis, you take a good chunk of that weight off the disc and you put it back on the facet joints. So listen, it'll reduce pressure on the disc, and that's not a bad thing. Hopefully it's enough to help the disc. If not, you may need to get the disc treated directly. Fatchun, are CXA, BDI, BAI, etc. worth measuring in flexion extension X-ray like measuring flexion extension MRI? You can probably do BDI. CXA is not going to be all that accurate, and BAI will be less accurate. The problem is that there's so many shadows in those x-rays where you can be off. Glasses are tilted again here. You can be off a good amount, 5-10 degrees, 5 degrees on either side, because you can't see where the margins are very clearly. So regrettably, those measurements are less accurate on x-ray and much more accurate on a CT scan or an MRI, where you can see those structures very clearly. And there, you could be off by 1 or 2 degrees. It's not going to make as big a difference. But obviously, if you're off by 10 degrees, something can be normal or abnormal just because it wasn't measured as well as it could have been because of all those different shadows. Sharon, how can you prevent from getting a hip replacement in patients with early degeneration? Certainly that's the goal, Sharon. In fact, I just saw a patient back yesterday whose hip we've been treating. I think time before last, we treated with PRP. Last time we treated with bone marrow, including a bone augmentation procedure. This time we were just treating it with bone marrow and articular again, and we had other spots to treat with bone marrow. But I was surprised. I would have expected at this point that her hip would be pretty fried, and she still had very, very good preservation of joint space. Now, is that evidence of anything but what happened in her? No, but that certainly is the goal of that kind of treatment. Regenexx, mid-advanced by Charlie Christoph. How long would we need to be in Colorado for each treatment? If you're referring to the DDD procedure, that's kind of a fly in and out thing. If you're referring to something else, let me know. Sharon, what causes flattening of the femur in hip joints? Yes, if you get flattening of the femur, that means that the bone itself is collapsing, and that is much less common in knee joints, but much more common in hip and ankle joints. And what causes that? It's just destruction of the bone. And normally what happens is, well, before that, the bone on MRI will show evidence of swelling. And then if that's not dealt with, eventually parts of the bone will start to die off. And then they'll wall off into cysts. And eventually, if the cysts aren't strong enough, then you'll see collapse of the bone and flattening of that femur. So that's what that's how that happens. Finn, have you ever monitored the growth regeneration of a ligament post-prolo, monitoring either functionally with DMX or visually by ultrasound or similar, wondering about nutrition timings for growth? I think I'm the only person on earth to do that study in the neck. Doesn't really talk about timings, but we did monitor the function of those ligaments pre and post prolo. So let me see if I can bring that one up for you. I think there it is. That was a long time ago, 2005, almost 20 years ago. Let me go ahead and bring that guy up here so I can show you where that lives. So this is the U.S. National Library of Medicine. This is the study that we published in 2005. We did it probably 2003 to 2004. And bottom line was we did see a reduction in the instability of lower cervical segments that had translation forward by tightening up the posterior ligaments with prolo. So that's that study there. Pia, what's the likely cause of motor changes and anything that can be done with regenerative meds? Yeah, Pia, motor changes are just when the bone, the vertebral bone, starts to get involved. The cause is just swelling within that bone and changes that happen at the end plate. As far as treating motor changes, it's possible to change them just with intradiscal injections. We've seen that happen. Sometimes it's also possible to treat the bone itself. Many times you don't need to treat either to get good results. Alicia, I just joined, but you were the only Regenexx place doing the DDD procedure. No, Ulysses. DDD procedure is done throughout our network. We're the only place doing a randomized controlled trial on the DDD procedure. So the lumbar DDD procedure is pretty commonly done throughout our network of about 80 clinics, but we're the only ones that have the infrastructure to do a randomized controlled clinical trial because we've got a full-time PhD research coordinator, we've got a full-time lab staff, we've got a full-time lab research staff. So we just have things that other Regenexx sites don't have. Aaron, are you still doing the PICL study? We are still doing the PICL study. So if you're interested in that, contact Aaron Dotson. Let me put that down here. So I'm putting Aaron's contact information in the comments. So if you want to reach out to Aaron, you can see if you're a candidate for that. Have you heard of osteopath? And did you do some of them do the regenerative medicine for the neck and other parts of the body too? Yeah, so an osteopathy degree, a DO rather than an MD, is generally an MD equivalent. And these days, there's not a lot of difference there. Now, as we always talk about, whether you're an MD or a DO doesn't make a difference. You then have to have dramatic additional training to be able to do spinal injections and keep the patient safe and hit certain targets. So it doesn't really matter if you're an MD or a DO. What matters is that you have that additional training to allow that kind of stuff to happen. And so, but MD or DO are generally equivalent these days. Bethany, higher Centeno with a shortness of breath and tight chest because more by CCI or severe disc bulge, spinal stenosis, phrenic nerve damage, already been cleared by a cardiologist at a normal exam. Generally, neither. There could be problems with CCI leading to that, but the first thing to look at would be whether or not there was some injury to the rib cage itself. Regenexx been advanced by Lane Wilson. Does being a little anemic exclude you from being a candidate for the DDD study? I'd have to know the extent of the anemia. What we would have to take probably half a blood bag, half a liter. Well, actually less than that, about 200 milliliters of blood. So we'd have to see what your size is, what your hematocrit is, what your sex is. All of that goes into a calculator. And then we use the AAB criteria as to whether or not we can take that much blood. Ulysses, so you mix platelet lysate and prolotherapy together. Is it worth it? Yeah, platelet lysate and prolotherapy can be mixed together. And there's no impact on the growth factors. We've studied that in the lab. What you can't mix together is prolotherapy and whole platelets, because then you create platelet raisins. Sharon, if the femur and hip joints are flattened, would you be deemed surgical? Yes, that's definitely a surgical case. That's not mild hip arthritis, that's severe. So that would be a severe hip arthritis situation. E. Dotson at Regenexx, that's Aaron Dotson's contact information. So if you're interested in the lumbar DDD study or any other study that we're currently doing, like the PICL study, then Aaron is your contact. Garrett, hi, Dr. Centeno. My DMX showed facet joint gapping. I believe you mentioned before injecting the facet joint capsules terminology used by some providers, but doesn't mean the facet joint was ever hit. When going PRP, PICL, Colorado, the ligaments that hold the actual facets able to be treated tightened. In other words, the facet ligament's not just because of the provider's training equipment, or rather than the facet-specific ligament. Yes, so if we think that's clinically important, meaning that we see a lot of facet gapping as part of just routine degenerative disease in the spine, but if we think that the facet gapping is directly linked to symptoms and symptom generation, then yes, we can actually target the facet capsules, unlike other providers, through just using that as a way to sort of cover up the fact that they don't have the ability to inject the facet joint itself. Sure, Aaron. Sharon, can osteophytes disappear over time? For example, when one got regenerative injections in hip joints and it's become more stable, there's no reason anymore for the joint to form osteophytes. Does not work like that. Generally doesn't work like that in the hip, and if you have collapse of the femoral head, really that level of hip osteoarthritis is not a candidate for regenerative injections in general. Finn, I've read reports recently of stenosis at 5'6", causing chronic fatigue and dysautonomia type symptoms. This was surprising to me, as its lower cervical, having other cases reflected this. Not in general. I think there's some guys out there who believe that cervical stenosis could be linked to more CSF-like, CFS or ME type symptoms. And it's possible, but there are ways to test that, right? You don't want to go and jack up someone's neck for life by opening up the back of the spinal canal and fusing them together without hard proof that what it is you're looking at is causing the symptoms. So you would want to, for instance, treat that area, You could even treat it with a high-dose corticosteroid epidural to get some sense that the patient is going to feel better in the short term, and that's where the problem is. You could also treat it with platelet-based treatment to see if you can prove that that area is responsible for a certain set of symptoms. So while I think it's an interesting concept, and there may be some patients out there like that, do I think it's super duper common? Not so much. I mean, if someone has a lot of cervical stenosis, they can get aches and pains all over the place. So that's pretty common, but you have to prove to yourself that that spot is what's causing the symptoms before you do an irreversible surgical procedure that can never be undone and destroys the normal biomechanics of the spine. So that's kind of what I think about that one. Ulysses, do you see a connection between muscular dystrophy or atrophy and instability in the spine like neck, mid, and low back? We do not. No. Okay, guys, so any other questions I can answer? Today we were talking about a lumbar DDD study, degenerative disc disease study. The focus of that study is to do a randomized controlled trial on using platelet-based procedures in the lumbar spine or low back for patients who have chronic low back pain and are fusion candidates. And the goal is to see, with a high-level rigorous study design, what those outcomes are, how many people are actually prevented from moving on to a fusion in the treatment group versus a sham injection group. Finn, for patients that don't have their instability resolved by PICL but have IJV and vagus compression, perhaps this is preferable. Let's see, Finn. No, you wouldn't want to decompress C5-6 without, again, some evidence that C5-6 is causing the symptoms. Because if you do that and C5-6 isn't causing the symptoms, you've permanently damaged somebody for life without any sense that you were going to help them. So that's the big problem there. Any other questions that I can answer here that anyone has, either about this topic of lumbar DDD procedure or the PICL study or anything else at all out there? Okay, going once, going twice. So thanks so much for joining us today. This will be a shorter one where we're just focusing on that lumbar DDD study. I think we got this here. Another question. Fatcha, what's the difference between CCI and cervicogenic headaches? Is there an overlap? Yeah, that's a good question, Fatcha. And one of the things I think that patients have a hard time realizing is they hear about CCI, but what they don't really hear about is that the upper neck can cause all of the same symptoms or many of the same symptoms as CCI without the instability. So that would be, you could call it a craniocervical syndrome versus craniocervical instability, but they both cause a similar symptom set, including headaches. So it's important to see if someone's unstable, because then you've got to treat, remember, specific ligaments, specific diagnosis, specific injection targets, specific treatment. But if they're not unstable, same thing. You've got to identify which of those injection targets could be causing headache. Okay, guys, you have a wonderful weekend. And I'll be back on Monday, and we will take it from there. So have a wonderful weekend. Thank you.